Hi everyone. Now we're going to do an important topic which is Rh negative pregnancy, and I know many of you during your undergraduate time you found this topic difficult, but believe me, if you understand the concepts behind Rh negative pregnancy, this is a very simple topic. You don't have to mug this topic. It is a very conceptual topic, and there are just a few algorithms which you need to remember on it. And then you won't do any question wrong in Rh negative pregnancy. So let's get going. First, let us see what are the Rh antigens. See, there are 5 Rh antigens. Small c, capital D, capital E and small e. Now my question to you is, do you know where are these Rh antigens present? So these Rh antigens, they are present on the short arm of chromosome 1. Right? Now, amongst all these 5 antigens, which is small c, capital D, capital E and small e, it is the capital D antigen which is the most important antigen. If capital D antigen is present, then it means the person is or the individual is Rh positive. And if capital D antigen is absent, then that means the individual is Rh negative. Now, this Rh antigens, they appear as early as 38 days of gestation on the RBC. So, in intrauterine life only, these Rh antigens appear on the RBC and they appear as early as 38 days of gestation. Right? Now, the other very important thing is, suppose there is an Rh negative individual, and this Rh negative individual is exposed to the RBCs of an individual who's Rh positive, right? So imagine, so suppose this is the circulatory system of an Rh negative individual. Now this is an Rh negative individual, and the RBCs in Rh negative individual, they do not have any D antigen or any Rh antigen. Now all of a sudden, if this individual is exposed to RBCs which have got Rh antigen, right? So this is Rh positive blood which has come inside the circulatory system of Rh negative individual. Now, because this Rh antigen is absent in this Rh negative individual, this Rh antigen will act like a foreign antigen. And this is going to stimulate the Rh negatives individual's immune system, and the immune system of the Rh negative person will form antibodies. What will they form? They will form antibodies against this Rh antigen. And this is what I have written for you over here. So if an individual is exposed, who is Rh negative, is exposed to RBCs of an individual who is Rh positive, the Rh negative individual's body will produce antibodies against the Rh antigen. Clear to all of you? Nothing to explain to you here? Okay. Now, this was in general about Rh negative. Now, let's talk about Rh negative pregnancy. What does Rh negative pregnancy means? Rh negative pregnancy means mother is Rh negative, fetus is Rh positive. Right? Remember, if mother is Rh negative and fetus is also Rh negative, then this is not a high-risk pregnancy, right? High-risk Rh negative pregnancy or at-risk Rh negative pregnancy means mother has to be Rh negative and fetus has to be, this was not high-risk, right? So in order to be called as a high-risk pregnancy or a high-risk Rh negative pregnancy, mother should be Rh negative and fetus should be Rh positive. The reverse is also not true. If mother is Rh positive and fetus is Rh negative, that is not an Rh negative pregnancy. Similarly, if both are Rh negative, then that is not a high-risk Rh negative pregnancy. We are concentrating on our high-risk Rh negative pregnancy, and whenever we say a high-risk Rh negative pregnancy or whenever we say Rh negative pregnancy, it simply means that mother is Rh negative and fetus is Rh positive. Now tell me, why is it that if mother is Rh negative, fetus is Rh positive? How is that possible? This is possible because it means that the father is Rh positive. Right? So if mother is Rh negative and father is Rh positive, there are 50% chances that fetus will be Rh positive and 50% chances that fetus will be Rh negative. right? And I am telling you that if mother is Rh negative and fetus is Rh positive, that is a problematic case. So this means that if father is Rh positive, there are 50% chances that fetus will also be Rh positive. And then it comes in high risk pregnancy. But if mother is Rh negative and father is also Rh negative, then 100% all the fetuses who are formed, 100% the fetus will be Rh negative. And this is not a high risk pregnancy. If fetus is Rh positive, that is a high risk pregnancy. And you will understand that why is it that when mother is Rh negative and fetus is Rh negative, it is not high risk? And why is it that when mother is Rh negative and fetus is Rh positive, then it is high risk? Just now you will understand everything. But over here, I want you to know that if mother is Rh negative, that means if your patient, if the antenatal patient who is coming to you, who visits you, and you do an ABO-RH typing. When do you do ABO-RH typing? In the first antenatal visit itself. And you come to know that your patient is Rh negative. What should be the logical next step? The logical next step is that you should find out husband's Rh status. Because if husband is also Rh negative, then I am not worried at all. Right? That patient becomes a low risk pregnancy. That is not a high risk pregnancy. But if husband is Rh positive, then I know 50% of the fetuses would be Rh positive and 50% Rh negative. So I don't know whether my patient is carrying an Rh positive or an Rh negative fetus, and I will call it as a high risk pregnancy. Clear? Okay. Now, why is there a problem if mother is Rh negative and fetus is Rh positive? So what is the problem? See, in Rh negative pregnancies, the problem is that during pregnancy, there are so many instances when there are chances of fetal blood leaking into mother's blood, right? There are chances of feto-maternal hemorrhage. Right? So fetal blood entering into mother's blood, that is what is called as feto-maternal hemorrhage. Now, if mother is Rh negative and fetus is Rh positive, so just now I told you that if mother is Rh negative, she is equal to the individual who's Rh negative. So in her RBCs, you will not get any Rh antigen. But if fetus is Rh positive, on the fetal RBCs, you are going to get Rh antigen. Now, if during pregnancy feto-maternal hemorrhage occurs and the fetal blood enters mother's circulation, what is going to happen? The Rh antigen which is present on fetal RBCs will act like a foreign antigen. And because it is going to act like a foreign antigen, it will stimulate the mother's immune system, and mother's immune system will form antibodies against this Rh antigen. Till here it is clear to all of you? Now, you know from your microbiology knowledge that initially the antibodies which are formed are IgM antibodies. And you also know this, that IgM antibodies cannot cross the placenta. Right? So even if antibodies are formed, it's okay because these IgM antibodies cannot cross the placenta. Right? So by the time IgG antibodies are formed, patient already has delivered, and that is why first pregnancy is safe in Rh negative mothers. Right? So the IgG antibodies are formed later. By that time, most of the time, the delivery has happened, and once delivery has happened, the baby is safe. So that is why first pregnancy is unaffected, or first pregnancy is safe in Rh negative mothers. Clear to all of you till here? Right? Now imagine this female becoming pregnant again. Now, in next pregnancy, if again her fetus is Rh positive, right? So, if again her fetus is Rh positive and suppose again feto-maternal hemorrhage occurs, Again, fetal RBCs which are containing the Rh antigen, they enter mother's circulation, and again they stimulate the mother's immune system. Now, this time, because the mother's immune system was already once exposed to the Rh antigen and the mother's immune system has already formed the antibodies once, so now the IgM antibodies which will be formed will be very quickly, right? And all of you know this. And quickly, the IgG antibodies will also be formed. So now mother's immune system will work very fast and it will form IgM antibodies quickly, and quickly it will form IgG antibodies. Now comes the problem, because IgG antibodies can cross the placenta. But then, yes, they can cross the placenta if they are produced in significant amounts. So if IgG antibodies are produced in significant amount, these IgG antibodies, which are against Rh antigen, they will reach the fetal circulation. So imagine fetal circulation over here. This is fetal circulation. In fetal circulation, we have RBCs, and on the RBCs, we have Rh antigen. Right? Now, what is mother doing? Mother is sending antibodies against Rh antigen. These antibodies which are against Rh antigen, they will cross the placenta, they will come into the fetal circulation, and antigen-antibody reaction will occur. Where will this antigen-antibody reaction occur? It is going to happen on the fetal RBCs, right? So once the antibodies reach the fetal circulation, what are they going to do? They are going to lead to hemolysis in the fetus. Are you understanding? So first pregnancy was safe. In second pregnancy, IgM antibodies and IgG antibodies are formed very quickly. And once IgG antibodies are formed in significant amounts, they quickly cross the placenta and they lead to antigen-antibody reaction, which is going to happen on the fetal RBC, right? And that is going to lead to hemolysis in the fetus. Now, when hemolysis is going to happen in the fetus, definitely there will be fetal anemia, right? And if there is severe fetal anemia, you all know that severe fetal anemia, it leads to heart failure. So if there is severe fetal anemia, it is going to lead to heart failure, and that is what is called as hydrops fetalis. Now, I'm going to talk to you about hydrops fetalis in detail, but just remember that hydrops fetalis is not a clinical diagnosis, right? It is a diagnosis on ultrasound. It is not a clinical diagnosis, right? Now tell me, whenever fetal anemia happens, what do you get? So there are two things when fetal anemia happen. So through the tests, we can come to know that anemia has happened in two ways. Number one, if you are doing CTG or if you are doing NST, and on CTG or NST, if you get sinusoidal heart wave pattern, this kind of fetal heart rate, sinusoidal heart rate pattern, that indicates anemia in the fetus. That anemia can be due to any reason. That anemia can be due to Rh negative immunized, Rh isoimmunized pregnancy. That anemia could be due to vasa previa. That anemia could be twin-to-twin transfusion syndrome, right? So anemia in the fetus due to any cause will lead to sinusoidal heart rate pattern on CTG or NST. Number two, when you do Doppler of middle cerebral artery, you will get increased peak systolic velocity. The peak systolic velocity in middle cerebral artery increases whenever there is fetal anemia. And how much does it increase? It becomes more than 1.5 MOM, more than equal to 1.5 MOM. Clear? So what has happened? Because of hemolysis, fetal anemia has happened. And because of fetal anemia, if there is severe fetal anemia, it is going to lead to heart failure. All of you know that the degradation product of RBC is bilirubin. So when hemolysis is going to happen, it can lead to jaundice. Now, when hemolysis is going to happen, where does fetal hematopoiesis happen? Fetal hematopoiesis occurs in liver, in spleen, and it happens in bone marrow. So if fetal RBCs are being destroyed, now the liver, spleen, and bone marrow will try to produce more RBCs to compensate this loss. So there will be hepatosplenomegaly, there will be bone marrow hyperplasia, and both of them will increase the erythrocytes. That is why this condition is also called as erythroblastosis fetalis. Right? Now, because hemolysis is happening, so the amount of the nutrients and the oxygen which is reaching the fetus will be less, definitely. So, placenta will try its best so that it gives more blood to the fetus. And that is why there will be placentomegaly. Right? So, because of hemolysis, these are the features which you get. You get fetal anemia. Fetal anemia could lead to high drops. You get jaundice. You get hepatosplenomegaly. You get bone marrow hyperplasia, which leads to erythroblastosis fetalis. And you get placentomegaly. So, as you can see here, that Rh negative pregnancy is posing a risk to the fetus. Right? Mother is Rh negative. This pregnancy is a high-risk pregnancy because this condition leads to fetal morbidity and mortality. Right? So it is mostly the fetus who is at risk in Rh negative pregnancy. Till here it is clear? So now if I ask you, can you think of any complications which happen in Rh negative mother because of Rh negative pregnancy? So if you remember my previous lectures, I told you in placentomegaly chapter video on placentomegaly, I told you that Rh negative is one of the reasons for placentomegaly, and just now also I told you that Rh negative isoimmunized pregnancy. Whenever we say Rh negative pregnancy in general, I am talking about this isoimmunized case over here. So Rh negative isoimmunized pregnancy, it leads to placentomegaly. Right? And placentomegaly means that the size of the placenta is increasing. The more is the size of the placenta, more are chances of PIH. So Rh negative pregnancy is a risk factor for PIH. Yes. Number 2, tell me what other thing? So if you remember the video on polyhydramnios, I told you in Rh negative pregnancy, because the size of the placenta is increasing, so there will be increase in maternal transudation across the placenta, and that is going to lead to polyhydramnios. Right? So the two very important maternal complications which can happen because mother is Rh negative and fetus is Rh positive are PIH and polyhydramnios. Right? So now, all this was happening. Why? This was happening because the fetus was Rh positive. So the RBC of the fetus, which was carrying the Rh antigen, entered into mother's circulation. Right? So this means if fetus is Rh negative and mother is Rh negative, will there be any complication? No. Even if feto-maternal hemorrhage happens, there won't be any complication because fetal blood doesn't have any Rh antigen. Mother's blood doesn't have any Rh antigen. No problem. So now have you understood why I said that if mother is Rh negative and fetus is Rh positive, then there is a problem. If mother is Rh negative, fetus is Rh negative, no problem. Similarly, if mother is Rh positive and fetus is Rh negative, again no problem. Right? Because if feto-maternal hemorrhage is going to happen, fetal RBCs which don't have any Rh antigen are entering into mother's blood. Right? So no immune reaction is going to happen. Are these things clear? Okay. Now, if these things are clear, there are certain other concepts which I want you to be clear about. Suppose I ask you, is there a way to prevent all these fetal complications? Think and tell me, is there a way to prevent all these fetal complications? Yes, there is one way to prevent all these fetal complications. Imagine this is the mother's circulatory system, right? So this is the mother and this is the fetus. So over here are maternal RBCs which don't contain any Rh antigen. So mother is Rh negative, fetus is Rh positive. So over here I have fetal RBCs, and these fetal RBCs, they have got Rh antigen. And feto-maternal hemorrhage happens. The fetal RBCs have entered into mother's circulation. Now suppose there is a policeman here. There is a policeman who is already there in mother's circulation, which the moment fetal RBCs enter the mother's circulation, right? So fetal RBCs with Rh antigen, when it enters the mother's circulation, this policeman destroys these RBCs before they could stimulate mother's immune system to produce anti-D, right? To produce antigens, antibodies against Rh antigens. So have you understood? There is a way. If I have a policeman which is there in mother's circulatory system, in mother's circulation, which can act immediately upon the fetal RBCs the moment they enter into mother's circulation, and they prevent the mother's immune system to get stimulated. The moment fetal RBCs are killed, the fetal RBCs will not be able to stimulate mother's immune system. And if mother's immune system will not get stimulated, it will not produce antibodies against Rh antigens. And if antibodies against Rh antigens are not produced, my problem is solved. Right? So this policeman, do you know the name of this policeman? This policeman is anti-D. Right? This policeman is anti-D. So what I'm doing is I am bringing anti-D into mother's circulation, which I am going to bring in less volume. So in very low concentration, I'm going to give anti-D to the mother. Now, because I give anti-D to the mother, this anti-D is already present in mother's circulation. The moment fetal RBCs with Rh antigens enter into mother's blood, because this anti-D was present, what is this anti-D? It is anti-D. So, it is antibody against the D antigen. Right? Antibody against Rh antigen. So, the moment fetal RBCs with Rh antigen enters into mother's circulation, these antibodies act on the Rh antigen and they bring about, they kill these fetal RBCs, they bring about hemolysis of these fetal RBCs in the mother's circulation so that they are unable to stimulate the mother's immune system. Right? Now comes the concept where I told you that a problem is going to happen only if anti-D is present or the antibodies are present in high volume. Or I told you, I made you like this. I told you IgG antibodies can cross the placenta only if they are in significant volume. Right? So now comes this concept that when I am giving anti-D, right, I am going to give anti-D in low concentration, 300 microgram of anti-D. And this 300 microgram of anti-D is capable of neutralizing 30 ml of feto-maternal hemorrhage or 15 ml of RBCs. Please don't write this just now. I'm going to make you write all this. First, understand, right? So this anti-D which you are giving is 300 micrograms of anti-D which you are giving to the mother, right, in order to prevent the fetal RBCs from stimulating the mother's immune system. And this 300 microgram of anti-D which you are giving can hemolyze only 30 ml of feto-maternal hemorrhage, right? So this means that just in case this anti-D, which is again of G type, it is IgG variety, if this anti-D, even if it crosses into fetal circulation, it is going to lead to limited hemolysis. First concept is because we are giving it in low concentration, it will not cross the placenta and not reach fetal circulation. But by chance, even if it reaches, I'm not worried because I've given a very small quantity of anti-D. And the small quantity of anti-D can only hemolyze 30 ml of feto-maternal hemorrhage or 15 ml of fetal RBCs. And 15 ml of fetal RBCs, hemolysis of 15 ml of fetal RBCs will not lead to this entire spectrum of anemia, hydrops vitalis, jaundice. No, this is not going to happen. Right? Have you understood? On the other hand, if I would have not given anti-D to the mother, and if fetal RBCs would have entered into mother's circulation and there wasn't any anti-D, this fetal RBC would have stimulated the mother's immune system to produce anti-D, antibodies against the Rh antigen, and we don't know how much of those antibodies would have been produced. Right? We don't have any control on those antibodies. Right? Mother could produce significant amount of antibodies, and those significant amount of antibodies could have crossed the circulation and led to all these complications. Are you understanding this concept? Right? So now I want you all to write when I'm telling you this concept again. So all fetal complications, they can be prevented if mother's blood has anti-D present before the fetal blood enters mother's circulation. How? Suppose if anti-D was present in mother's circulation before fetal blood containing Rh antigen entered mother's circulation, the anti-D present in mother's blood would have destroyed the fetal blood and the Rh antigen before it could stimulate mother's immune system to produce excessive anti-D. Right? So it would have destroyed the fetal RBC along with the Rh antigen even before it could stimulate the mother's immune system to produce excessive anti-D. Only if excessive anti-D IgG type is present or it is produced by the mother's immune system, then only it crosses the placenta in significant amount to cause severe hemolysis. Right? Hence, we give injection anti-D, which is 300 micrograms to Rh negative pregnant females to prevent their immune system from producing excessive antibodies if feto-maternal hemorrhage occurs. The 300 microgram of anti-D is sufficient to neutralize only 30 ml of feto-maternal hemorrhage or 15 ml of fetal RBCs. Therefore, even if it crosses the placenta and reaches fetal circulation, it will not cause as much hemolysis as the antibodies produced by the mother's immune system. Right? So this I told you so that you can just write all the important points. I hope you've understood the concept behind giving anti-D. Now, if you've understood the concept behind anti-D, behind giving injection anti-D, you will also appreciate the fact and you will also understand this fact that anti-D will be beneficial only if it is given before the fetal RBCs could stimulate mother's immune system. Right? Only then anti-D would be beneficial. Suppose if fetal RBCs have already entered into mother's circulation and you give anti-D, then the fetal after that. So then the fetal RBCs would have already stimulated the mother's immune system. Mother's immune system would have already started producing antibodies which we didn't want. Now giving anti-D is of no use. So if you have to give anti-D, anti-D injection will be beneficial only if it is given before fetal RBCs enter mother's circulation and before they stimulate mother's immune system. In other words, anti-D injection is beneficial only in an Rh negative unsensitized mother. So a female in whom the fetal RBCs have not yet entered her circulation and fetal RBCs have not yet stimulated the immune system to produce antibodies, such Rh negative females are called as unsensitized females. So this means that giving anti-D is beneficial only and only to an Rh negative unsensitized female. Clear? Have you understood this? So then, how am I going to know whether my patient is already sensitized or she's unsensitized? This you can come to know by doing an investigation which is called as the indirect Coombs test. Indirect Coombs test. Indirect Coombs test, the sample you are going to take from mother's blood. It is done on mother's blood, right? So whenever I have an Rh negative female who's coming to me for antenatal visits, I am going to, on the first antenatal visit, I'm going to do her indirect Coombs test, right? And I'm going to repeat it at 28 weeks of pregnancy. If the indirect Coombs test remains negative, if indirect Coombs test remains negative, what does that mean? Indirect Coombs test remains negative. So please write over here. Indirect Coombs test negative means that there is Rh unsensitized female. And indirect Coombs test positive means she is Rh sensitized female. What do you understand by Rh sensitized female and Rh unsensitized? Rh unsensitized means that the mother's immune system has not yet been stimulated. Rh sensitized means her immune system has already been stimulated. So now tell me that if I am doing in an Rh negative female, I am checking her indirect Coombs test at the first antenatal visit, and then I am doing it again at 28 weeks of pregnancy. And if I see that the indirect Coombs test remains negative, what is the next logical step? The next logical step is that give her anti-D, because anti-D is beneficial only in Rh negative unsensitized females. Right? So if the female, the pregnant Rh negative female, is her indirect Coombs test is negative at 28 weeks, at 28 weeks, I am going to give her anti-D. Right? How much anti-D I am going to give? 300 micrograms of anti-D, which is same as 1500 international units of anti-D. And then I can be sure that now no more complication is going to happen. And in such females, these are called as the unsensitized Rh negative females. In unsensitized Rh negative females, why have I given anti-D? Why have you given to unsensitized Rh negative females anti-D? You have given anti-D to protect this pregnancy. Right? So now I can be sure that this pregnancy is protected. Now I am going to do nothing. I'm just going to deliver her. And when am I going to deliver her? I am going to deliver her between 39 to 40 weeks. What will be the mode of delivery? Mode of delivery will be vaginal delivery. Right? Am I going to do early cord clamping or delayed cord clamping? I do not want the mother to get sensitized after delivery. Right? So I am going to go for early cord clamping. Why early cord clamping? To prevent sensitization during delivery. Right? Clear to all of you till here? Now, once this female has delivered, now what I'm going to do is I am going to check the Rh status of the newborn. If Rh status of the newborn is Rh positive, if the newborn is Rh positive, I am going to now do a direct Coombs test. A direct Coombs test. This direct Coombs test is done on newborn's blood. So indirect Coombs test was done on maternal blood. Direct Coombs test is done on the newborn baby's blood, right? And if direct Coombs test is also negative, if in direct Coombs test is also negative, again I am going to give anti-D 300 micrograms to the mother, right? This is called as postpartum prophylaxis. Right? Please just make a small change over here. When you are giving at 28 weeks of pregnancy, when you are giving 300 micrograms of anti-D to the pregnant female, definitely you are giving anti-D to the unsensitized Rh negative pregnant female. And this is called as, where I have written called as, this is called as antepartum prophylaxis. This is called as antepartum prophylaxis. So that's the drawback of when you just make fill in the blanks, right? So this is called as antepartum prophylaxis when you were giving anti-D at 28 weeks of pregnancy to the Rh negative unsensitized mother, to the Rh negative female whose indirect Coombs test was negative. Now, when you are giving anti-D to a female who has delivered, right? And when direct Coombs test has come out to be negative, that is called as postpartum prophylaxis. So during pregnancy, when you were doing at 28 weeks, that was antepartum prophylaxis. The aim of antepartum prophylaxis was to protect the present pregnancy. The aim of postpartum prophylaxis is to protect next pregnancy. The delivery has already happened, right? So my aim is not to protect present pregnancy. Now my aim is to protect next pregnancy, right? At what time are you going to give anti-D? The ideal time to give anti-D is within 72 hours of delivery or cesarean section, whatever. If the patient had undergone vaginal delivery, then within 72 hours of vaginal delivery. If patient had undergone cesarean section, then within 72 hours of cesarean section. But then it can be given up till 28 days. So when you will be working in government hospitals and you are going to, because this injection is a costly injection, so you can, when you ask the husband or the relatives to get this injection, so many times they are not able to arrange money within 72 hours to buy this injection. So in that case, yes, you can give it up till 28 days. But maximum efficacy is if it is given within 72 hours of delivery. So all the undergraduate students who are going to get a case of Rh negative pregnancy, it is very important for you to take history of whether anti-D was given in previous pregnancy or not after delivery. And most of the times your question should be that were you given an expensive injection or a costly injection after delivery? Because this is such a costly injection, I mean, for the low socioeconomic status people, that they do remember that yes, an expensive injection was given after delivery. All right. Now, tell me, what are you going to do if the patient says that I want a postpartum sterilization done? Now, in that case, are you going to give her anti-D or you're not going to give anti-D? See, the guidelines say that you should give her anti-D even if she says, I want a postpartum sterilization, because the female may change her mind, right? So the international guidelines say that anti-D should be given even if she says that she wants postpartum sterilization, right? Okay. This is what we had done. If indirect Coombs test was negative, we had given injection anti-D at 28 weeks of pregnancy, and then we had carried the pregnancy up till 39 to 40 weeks. Between 39 to 40 weeks, we had delivered. We preferred mode of delivery is vaginal delivery. After vaginal delivery, on the newborn's blood, first of all, I'm going to check whether the newborn is Rh positive or Rh negative. Only if newborn is Rh positive and the direct Coombs test is negative, then you have to give postpartum prophylaxis. If newborn is Rh negative, then you don't have to give postpartum prophylaxis. So there is no need to give postpartum prophylaxis if newborn is Rh negative. Clear? Now suppose when you did indirect Coombs test at 28 weeks, the indirect Coombs test came out to be positive. Now if indirect Coombs test comes out to be positive, this is called as an Rh negative sensitized pregnancy. Rh negative sensitized pregnancy. Now, is there any use of giving anti-D? If already the fetal RBCs have entered into mother's circulation and if already they have stimulated the mother's immune system, now there is no use to give anti-D, right? In such females, how should I manage? So, in such females, if the fetal RBCs have entered into mother's circulation and they have stimulated the immune system, Now mother is producing antibodies against Rh antigens. Now I told you that if antibodies are in significant amount, if IgG variety of antibodies is in significant amount, then it will cross the placenta and it is going to lead to the entire cascade of events. So now the second thing is, if I see that indirect Coombs test is positive, now my mind is thinking whether the antibodies are produced in significant amount in my patient or whether they are in less amount. Because if they are in less amount, still the fetus is safe. But if they are in significant amount, I'm worried about the fetus. Right? So how am I going to know whether the antibodies are produced in significant amount or whether they are produced in less amount? So that test is the antibody titer. I should go for antibody titer. So suppose your question says that there is a pregnant Rh negative female in whom at 28 weeks indirect Coombs test came out to be positive. What is the next step? Please do not say next step is anti-D. So I am giving you these two cases and you people get so much confused. Case 1 is a pregnant Rh negative female. At 28 weeks, indirect Coombs test is negative. What is the next step? So yes, if indirect Coombs test is negative, next step is anti-D. Injection anti-D, 300 micrograms, which you have to give intramuscularly. Case 2 is you have a pregnant female who is Rh negative, and at 28 weeks of pregnancy, indirect Coombs test comes out to be positive. And now they ask you what is the next step. It will be a blunder if you say that now the next step is anti-D. Now the next step is antibody titer. Are you understanding, all of you? No one is going to make this mistake. Yes? So now my next step is antibody titer. Why am I doing antibody titer? Because only if anti-D antibodies are in significant amount, then they cross the placenta to cause hemolysis. So now I want to see whether they are in significant amount or not. And in order to know whether they are in significant amount or not, there is something which is called as the critical titer. And the critical titer is 1:16. Right? First understand, what do you mean by 1:16 or what do you mean by this critical titer? Critical titer means what I'm going to do in mother's blood, I'm going to go for serial dilutions of mother's blood. Right? And once I am diluting the mother's blood, I'm seeing at what dilution the antibody is present. So suppose I diluted mother's blood to 50%, right? So I added 50% water, 50% blood, right? So in this dilution, it is 1:2 dilution. So in 1:2 dilution, if antibodies are present, I'm okay with it, right? They are not significant. If in 1:4 dilution antibodies are present, still I'm okay with it. If in 1:8 dilution antibodies are present, I'm still okay with it. But if I have diluted mother's blood to 1:16 dilution and still antibodies are present, that means it's significant antibody. Right? So if in 1:16 dilution antibodies are still present, that is significant. Similarly, if in 1:32, 1:32 means significant. 1:64 means significant. Right? So do not apply maths here when I say that if antibodies are present in 1:16 dilution and more than that, then it is significant. So many times you people say that, ma'am, 1:8 is more than 1:16. So this means if antibodies are present in 1:8 dilution, then they are significant. No, please don't apply maths here that 1 divided by 8 is more than 1 divided by 16. That is why I have told you, we are talking about dilution. So if you have diluted the blood to 16 times and then antibodies are present, that is 1:16 dilution, and that is significant antibody. Similarly, if you've diluted blood to 1:32 times and still antibodies are present, that is a significant a number of antibodies. Clear to all of you? So once I get that the indirect Coombs test is positive, I have to check the antibody titer in my patient, knowing this that the critical titer is 1:16. So if the mother's antibody titer is less than 1:16, she shows me antibody only in 1:2 dilution, or only in 1:4 dilution, or only in 1:8 dilution, then that means just now significant antibodies are not there. So this means significant number of antibodies are not present. Right? And if significant number of antibodies are not present, still I am okay. But then, yes, I have to keep doing repeating titers. I have to keep this baby under surveillance as well. Right? So what I'm going to do, I'm going to repeat the titer every 4 weeks. After every 4 weeks, I'm going to repeat the titer. And once I see that the titer has started increasing, right? So suppose it was 1:2, and then next time when I took the titer, it came out to be 1:4. Now, if I see that the titer is increasing, then next time, instead of repeating the test after 4 weeks, I'm going to repeat it after every 2 weeks. If titer remains 1:2, 1:2, 1:2, I will keep on repeating the titer after every 4 weeks. But if I see, no, the titer has started rising, then I'm not going to wait for 4 weeks to repeat the titer. Then I'm going to repeat the titer after every 2 weeks. And I am going to do fetal monitoring. Fetal monitoring, it has to begin at 32 weeks of pregnancy. So beginning at 32 weeks of pregnancy, I'm going to do fetal monitoring, and I am going to deliver my patient between 37 to 38 weeks of pregnancy. In other words, I'm going to do induction of labor between 37 to 38 weeks. In unsensitized Rh negative females, we were doing delivery between 39 to 40 weeks. Now, in this case, when the antibody titer when the mother is sensitized but antibody titer is less than the critical titer, I'm delivering her between 37 to 38 weeks. So this is if her titer has not yet reached critical titer or is not more than critical titer. Suppose if the antibody titer is more than equal to 1:16, either it is 1:16 or 1:32 or 1:64, that means it's a critical titer, and that means significant antibodies are present. And if significant antibodies are present, they will cross the placenta and they are going to lead to hemolysis. So now what am I worried about? Now I know hemolysis has happened. Now I want to look for fetal anemia. How much is the fetal anemia now? And the non-invasive test to know how much whether fetal anemia is present or not is Doppler of middle cerebral artery, where I am going to check the peak systolic velocity. So I'm going to do a Doppler of middle cerebral artery, and I'm going to check the peak systolic velocity. So this Doppler of middle cerebral artery, it acts like a screening test for fetal anemia. It tells you whether fetal anemia is present or not. It will not tell you exactly that yes, this is the hematocrit or this is the hemoglobin. No, it is just going to tell you whether fetal anemia is present or not. Right? So what am I going to do? I'm going to do peak systolic velocity of middle cerebral artery. If peak systolic velocity of middle cerebral artery is more than equal to 1.5 mom, I know fetal anemia is present. Right? This is the concept which I told you a few minutes back as well. And this is the concept which I've also discussed in OBS radio integration. Right? So if antibody titer is more than equal to 1:16 and they ask you what is the next step, what is the next step? The next step is peak systolic velocity of middle cerebral artery. Right? You have to check the peak systolic velocity of middle cerebral artery with the help of Doppler. If peak systolic velocity is less than 1.5 mom, that means that just now anemia has not happened in the fetus. In that case, I am going to repeat peak systolic velocity of middle cerebral artery every 1 to 2 weeks. I am going to do a fetal surveillance, and fetal surveillance I'm going to begin at 32 weeks. How am I going to do the fetal surveillance? I'm going to do fetal surveillance by doing NST and biophysical profile weekly. And again, I'm going to deliver the patient between 37 to 38 weeks, right? So like you were doing previously, if antibody titer was less than 1:16, you were repeating it every 4 weeks. And if it was increasing, you were repeating it after every 2 weeks. Over here, if peak systolic velocity is less than 1.5 mom, you are repeating it after every 1 to 2 weeks. You are keeping the fetus under surveillance by doing NST and biophysical profile weekly. And you are delivering this patient between 37 to 38 weeks. Is this clear to all of you? Now, suppose if peak systolic velocity comes out to be more than equal to 1.5 mom. As I told you that this is just a screening test. It will tell you whether anemia is present or not. It is not going to tell you how much anemia is present. It simply tells me that yes, fetal anemia is present. Now, if fetal anemia is present, it is very important for me to know what is the hemoglobin and what is the hematocrit of the baby, because my next set of management, my next step in management is going to depend upon whether fetal anemia is significant and what is the gestational age. So there are many factors which are going to decide what am I going to do next. And one of those factors is how much is exactly the hemoglobin of the fetus or the hematocrit of the fetus. So if I want to know exactly the fetal hemoglobin and hematocrit, what do you think I should do? I should take out blood, right? I should take out, this has to be done. You should take out fetal blood. And from where are you going to take out fetal blood? You are going to take out fetal blood from the umbilical cord. And that is what is called as chordocentesis. Right? So once the screening test comes out to be positive, that yes, anemia is present, it becomes very important for me to know exactly how much is the hemoglobin of the fetus, exactly how much is the hematocrit of the fetus. And for that, I will have to take out fetal blood, which I'm going to take from the umbilical cord, and the procedure is called as chordocentesis. So if someone asks you what is the indication for chordocentesis, this is the only indication for chordocentesis. These days, chordocentesis is done only for one indication, and that indication is in Rh negative sensitized mother. In Rh negative sensitized mother, if peak systolic velocity is more than equal to 1.5 mom, then you do chordocentesis, right? Now, suppose I have done chordocentesis and I get that hemoglobin of the baby, of the fetus, is less than 2 standard deviation below. So it's less than 2 standard deviations below, or hematocrit is more than 30%, right? So if hemoglobin is less than 2 standard deviations below and hematocrit is more than 30%, this means it is mild anemia just now. It is not severe anemia. And in this case, again, what am I going to do? I am going to repeat hemoglobin and hematocrit weekly. I am going to do a fetal surveillance, which is going to begin at 32 weeks and which will comprise of NST and biophysical profile weekly. And I am going to deliver my patient between 37 to 38 weeks. The way you had managed peak systolic velocity at less than 1.5 mom, same here you are going to do if you see that the fetus has mild anemia, right? But if hemoglobin of the fetus is more than 2 standard deviations below, or hematocrit is less than 30%. Now this means that there is severe anemia. And if there is severe anemia, there are high chances of heart failure in the fetus or hydrops fetalis in the fetus. So in this case, next you should look at the gestational age. If gestational age of the pregnancy is more than equal to 35 weeks, earlier this was 34 weeks, now it has been revised to 35 weeks, then go for delivery. If it is less than 35 weeks, then go for intrauterine blood transfusion. Intrauterine blood transfusion. So intrauterine, I'm going to give blood to the fetus. Intrauterine blood transfusion. I hope you've understood this. Yes? So, in short, if you are having peak systolic velocity more than equal to 1.5 mom, the next step becomes you have to do chordocentesis, and on chordocentesis, if there is mild anemia, you have to carry on the pregnancy till 37 to 38 weeks, but under continuous surveillance, which means hemoglobin and hematocrit to be measured after every week, then fetal surveillance to be started from 32 weeks, and an STN biophysical profile to be done weekly. But if there is severe anemia, that is hematocrit is less than 30%, fetal hematocrit, then if the pregnancy is more than 35 weeks, deliver. If pregnancy is less than 35 weeks, go for intrauterine transfusions. Now, when you are doing delivery in a sensitized Rh negative pregnant female, the mode of delivery is the same. You go for vaginal delivery, right? So we are going for vaginal delivery. Now tell me, are you going to go for early cord clamping or delayed cord clamping? In this case, see, already the mother is sensitized. If mother is already sensitized, there is no use of doing early cord clamping. Early cord clamping was done to prevent sensitization. And in this case, already mother is sensitized. So if already mother is sensitized, there is no use of early cord clamping. Why not let the blood go to the fetus? Right? So in this case, I'm going to go for delayed cord clamping. Now, if your question comes like this, in Rh negative pregnancy, we go for early cord clamping or delayed cord clamping. Simple. They have not told you whether it's a sensitized mother or an unsensitized mother. Mark it as early cord clamping. If they say Rh negative pregnancy with indirect comb test negative, then also go for early cord clamping. If they say Rh negative pregnancy with indirect comb test positive, go for delayed cord clamping. Clear to all of you? Yes? Okay. Now, if I hope you've understood the basic concepts of Rh negative pregnancy. Now, if you've understood the basic concepts, there are just a few more things which I want you to understand. Just now I was telling you that when you give 300 micrograms of anti-D or 1500 international units of anti-D, how much feto-maternal hemorrhage it can neutralize? It can neutralize up till 30 ml of feto-maternal hemorrhage or fetal RBCs up till 15 ml. And generally, the feto-maternal hemorrhage after delivery is less than 4 ml most of the times. So whether it is delivery by vaginal delivery or delivery after cesarean section, most of the times feto-maternal hemorrhage is less than 4 ml after delivery. Right? And so if we are giving 300 micrograms of anti-D or 1500 international units of anti-D as a postpartum prophylaxis, that's absolutely fine. But many a times what happens is that there is increased feto-maternal hemorrhage. Increased feto-maternal hemorrhage happens if patient has history of abdominal trauma, if you have done instrumental delivery, in twin deliveries, in case of intrauterine death of the fetus, in case of manual removal of placenta. So in these cases, feto-maternal hemorrhage is more. And if feto-maternal hemorrhage is more, I need to know how much is the feto-maternal hemorrhage. Is it more than 15 ml? Because if it is more than 15 ml, the dose which I am giving is insufficient. Or is it less than 15 ml? Right? So how can I know that whether the feto-maternal hemorrhage which has happened is more or less? For this, we have a screening test, and the screening test is called as the Rosette test. Rosette test. If Rosette test comes out to be positive, then you go for the test which tells you exactly how much is the feto-maternal hemorrhage. Rosette test is going to just tell you, it's a screening test, whether feto-maternal hemorrhage. So this tells whether feto-maternal hemorrhage is more or less. It simply tells you this much, right? Now, if you want to know exactly how much is the feto-maternal hemorrhage, exactly to know the volume of feto-maternal hemorrhage, the test which we do is Kleehor-Betke test. Right? So, if feto-maternal hemorrhage is more, Rosette test comes out to be positive. And if feto-maternal hemorrhage is less, Rosette test is negative. So if I am suspecting that my patient had history of abdominal trauma, or if I've done a manual removal of placenta and I'm suspecting that there could be more feto-maternal hemorrhage, the screening test which I can do is a Rosette test. Rosette test will simply tell me whether more feto-maternal hemorrhage has happened or less. And if I get Rosette test positive, which means feto-maternal hemorrhage is more, then in order to know how much feto-maternal hemorrhage has happened, I'm going to go for Kleehor-Betke test. But there are some centers, there are some places where Rosette test is not available. In that case, you can directly do Kleehor-Betke test. So you may do a Rosette test, and then if it comes out to be positive, Kleehor-Betke test, or you may directly go for Kleehor-Betke test, right? Now, Kleehor-Betke test, it should be done within 2 hours of delivery. It is a quantitative test which is going to tell you the volume of feto-maternal hemorrhage, and based on the volume of feto-maternal hemorrhage, you can calculate the dose of anti-D. How are you going to calculate the dose of anti-D? Since very long, I am telling you that 300 microgram of anti-D injection can neutralize 30 ml of feto-maternal hemorrhage or 15 ml of fetal RBCs, right? So, applying basic maths, for every 1 ml of extra fetal blood which enters into mother's circulation, you are going to give additional 10 micrograms of anti-D. 300 micrograms was needed for 30 ml. So, 10 micrograms is needed for every 1 ml of extra blood. Right? So, for every 1 ml of extra blood which enters into mother's circulation, you have to add 10 micrograms of anti-D. Clear to all of you? Yes? So, remember that Kleehor-Betke test is a quantitative test. There is another test which can tell you that yes, feto-maternal hemorrhage has happened in mother's circulation, and that is Singer's alkali denaturation test. Singer's alkali denaturation test is a test which helps in differentiating vasa previa from placenta previa. Right? It is a qualitative test. It is not a quantitative test. Whereas Kleehor-Betke test is a quantitative test, and it helps you in knowing exactly how much feto-maternal hemorrhage has happened and in calculating the dose of anti-D. Right? Now, what are the other indications for giving anti-D? See, feto-maternal hemorrhage, as I told you in the beginning of the lecture, feto-maternal hemorrhage, fetal blood can enter into mother's circulation when bleeding happens, or when you are doing certain procedures, like if you are doing chorionic villi sampling, amniocentesis, versions. So this, or if you've done vaginal delivery, cesarean section, if you've performed MTP, ectopic pregnancy, you've managed ectopic pregnancy. So in all these conditions, because there are chances of feto-maternal hemorrhage, in all these conditions, you have to give anti-D, right? So let me tell you, in 2 columns, you are going to write the indications for giving anti-D. Indications for giving anti-D in first trimester, after abortion. So if you've done an abortion by any method in Rh negative female, then or if it is a spontaneous abortion, then too you are going to give her anti-D. Then after ectopic pregnancy, after molar pregnancy, and after chorionic villi sampling. Right? So after all these procedures in an Rh negative female, you have to give anti-D. As far as abortions are concerned, when you have to give anti-D and when not, I have told you in the video on abortions itself. Right? Now, In all these cases, if the period of pregnancy is less than 12 weeks, then the dose of anti-D which you have to give as per the American College of Obstetrician and Gynecologist, which we follow in India as well, is 50 micrograms. But the same thing, the Royal College of Obstetrician and Gynecologists say that whether it is less than 12 weeks, whether it is more than 12 weeks, it hardly matters. Every time you have to give 300 micrograms of anti-D. But we are following American College of Obstetrician and Gynecologist, and we give at less than 12 weeks, we give 50 micrograms of anti-D. Now, what are the indications for giving anti-D in second or third trimester? In second or third trimester, after amniocentesis, after external cephalic version or internal cephalic version, after any unexplained bleeding, after antepartum hemorrhage or fetal death or abdominal trauma. And the dose which you have to give is 300 micrograms of anti-D intramuscularly, apart from the reasons which I told you where you have to give earlier. To all Rh negative females in whom indirect Coombs test comes out to be negative, you have to give it at 28 weeks of pregnancy, right? And after delivery, you have to give it only if fetus is Rh positive and direct Coombs test is negative. So apart from that, these are the other indications for giving anti-D. Now, for all the foreign medical graduate students, this is the most important part of the video for you. Indications for giving anti-D injection, right? Then, now coming to some important case studies. So I was telling you that you have to give anti-D after chorionic villi sampling and after amniocentesis. Now the confusion comes, are you going to give anti-D after chordocentesis? Now I want all of you to recall the concepts which I have been telling you in this video throughout. I told you one concept, that the only indication for chordocentesis is if in Rh negative female, indirect Coombs test is positive and peak systolic velocity is more than 1.5 mom. Right? That is the only indication for doing chordocentesis. So this means if you are doing chordocentesis, already the mother is sensitized, and that is why you are doing chordocentesis. There is only one indication. This is the indication. You have to do chordocentesis only if mother's indirect Coombs test is positive and her peak systolic velocity is more than 1.5 mom. And if mother's indirect Coombs test is positive, is there any role of giving anti-D? No. So simply if they ask you, you are doing chordocentesis, should you give anti-D to the mother? No, you shouldn't be giving anti-D, right? So have you understood this? The second case scenario. If there is a pregnant female, Rh negative female, to whom you had given anti-D during pregnancy, and within 3 weeks of giving anti-D, the female has delivered, right? Now, after delivery, should you give anti-D, right? So in this case, after delivery, do not give anti-D, because the T half of anti-D, as the T half of anti-D is 28 days. So already anti-D is present in mother's circulation. So if you've given anti-D to a pregnant female and within 3 weeks she delivers, then there is no need to give anti-D after delivery, right? Then, apart from these Rh antigens, which are major antigens, there are certain minor antigens which are present on RBC, right? And some of these minor antigens, they have a risk of sensitization. They carry a risk of sensitization. Some of them, they don't have any risk of sensitization. And this is very oftenly asked question. So those minor antigens which carry some risk of sensitization are KEL, KID and Duffy A antigens. Now, there are certain minor antigens which do not carry any risk of sensitization, which means, so suppose if fetus is Lewy antigen positive and mother is Lewy antigen negative, and if fetal blood enters mother's circulation, there won't be any risk of sensitization. Whereas if fetus is KEL antigen positive and mother is KEL antigen negative, then there is some risk of sensitization in the mother, right? So the ones which do not carry any risk of sensitization are Lewy antigen, I antigen, and Duffy B antigen. Now, amongst these minor antigens, which antigen is most commonly does it lead to sensitization? The most common one amongst these which leads to sensitization is KEL antigen. KEL antigen leads to sensitization after blood transfusion. So it generally leads to sensitization after you've done a mismatched blood transfusion, right? Now I'm asking you most common non-D alloimmunization. So there was Rh antigens were of 5 varieties: small c, capital D, capital E, and small e. So just now we have talked about the D antigen, right? Now I'm asking you most common non-D alloimmunization. The most common non-D alloimmunization is the E antigen alloimmunization, right? So alloimmunization with E, that is anti-E immunization. So you can write anti-E immunization. Now this is most common. Which is the most severe non-D alloimmunization? The most severe non-D alloimmunization is anti-C alloimmunization, right? Have you understood this? So we have talked about D antigen, which is generally the most common. But if they ask you most common non-D is E. And most severe non-D is C, right? Amongst minor antigens which can lead to sensitization are KEL, KID, and Duffy A. Amongst them, which is the most common? Amongst them, it is the KEL which is most common. Clear to all of you? If they ask you minor antigens, you are going to talk about KIL, KID, and Duffy A. If they ask you non-D, then you are going to talk about C and E. Right? Do not confuse between the two. Minor means they are talking about KIL, KED, Duffy, Lewy, all these. Non-D means they are talking about C or E. Clear? Now there is something which is called as the mirror syndrome or the Ballantyne syndrome. It's nothing. It is that both mother and fetus are mirror images of each other. For example, in anti-D isoimmunization, right? So for example, an Rh negative sensitized mother. Now if an Rh negative sensitized mother, suppose severe hemolysis has happened in the fetus. So in the mother, there is going to be polyhydramnios, there is going to be PIH. Now because of polyhydramnios and PIH, mother appears bloated and swollen, right? And when the baby will be born, because of severe hemolysis, there can be hydrops. And because of hydrops, baby has pericardial effusion, ascites. So baby appears, very swollen. So it looks as if mother and baby are mirror images of each other. That is what is called as the Ballantyne syndrome. Right? So Ballantyne syndrome, it is not just seen in anti-D isoimmunization. It can be seen in twin-to-twin transfusion syndrome, in cystic hygromas, and in placental cholangiomas. So these are small questions which are asked. They are single liner questions which you should be well versed with. The last thing before I end this video is hydrops fetalis. Now, as I told you, hydrops fetalis is an ultrasound based diagnosis. On ultrasound, any two of the following four should be present to say that your fetus has hydrops fetalis. These are number 1, pericardial effusion, number 2, ascites, number 3, pleural effusion, and number 4, subcutaneous edema. Out of these 4, if any 2 or more than 2 are present, then we say that the fetus has developed hydrops fetalis. Hydrops fetalis happens due to severe anemia leading to heart failure, right? So although placentomegaly and polyhydramnios are coexisting findings which you get if fetus has hydrops fetalis, but polyhydramnios and placentomegaly are not included in the diagnostic criteria of hydrops fetalis. Right? Placentomegaly and polyhydramnios will be seen in Rh negative sensitized mothers. So yes, they can be seen in hydrops fetalis also, but they are not the diagnostic criteria for hydrops fetalis. The diagnostic criteria for hydrops fetalis is number 1, pericardial effusion, pleural effusion, ascites, or subcutaneous edema. Now tell me, which is the first sign of hydrops fetalis on ultrasound? The first sign of hydrops fetalis on ultrasound is scalp edema or subcutaneous edema, which appears as if there is a halo around the fetal head, and that is what is called as the Buddha sign. Right, so the first sign of hydrops fetalis is scalp edema. They can be which appears as if there is a halo around the fetal head, like Lord Buddha had. So this over here, if it is the fetal head, you are going to get a halo around the fetal head. It appears as if there is halo because of the edema, scalp edema. Right, this is what is called as Buddha sign. Now, hydrops fetalis, it is not only seen in Rh negative pregnancies, it can be seen due to other causes as well. So, if hydrops fetalis happens due to Rh negative pregnancy, right, it is happening in a case of Rh negative pregnancy, it is called as immune hydrops fetalis. But if it is not happening in Rh negative pregnancy, it is happening due to some other cause that is called as non-immune hydrops fetalis. Remember, non-immune hydrops fetalis is more common than immune hydrops fetalis. Right? Now, in an Rh negative pregnancy, when do you suspect that hydrops fetalis would have occurred? We suspect hydrops fetalis would have occurred if the fetal hemoglobin comes out to be less than 5 gram% or hematocrit becomes less than 15%. In these conditions, I suspect hydrops fetalis and I should go for an ultrasound. Right? Then, what are the causes of non-immune hydrops fetalis? The most common cause of non-immune hydrops fetalis is cardiovascular anomalies. Other than that, chromosomal anomalies, infections like parvovirus B19 infections, and anemias. So, non-immune hydrops fetalis is most commonly caused by cardiovascular anomalies, or it can be caused by chromosomal anomalies, then infections like your parvovirus infections and torch infections. Certain torch infections can also lead to hydrops fetalis, and then anemias and thalassemias. So these are the causes of non-immune hydrops fetalis. Right? Clear to you? Or have you all understood this? Most of the times they are going to ask you that what is the cause of hydrops fetalis? Please do not say that the most common cause is Rh negative pregnancy. No. The most common cause is cardiovascular anomalies. Right? So this is all what you had to remember on hydrops fetalis, and this is all what you had to remember on Rh negative pregnancy. I hope all of you have understood Rh negative pregnancy well. Take care. Keep practicing questions. Bye-bye.